All right, good evening, everyone. Thank you so much for joining us on our event today. I'd like to welcome you to the first event of this kind, the All of Us Research Programs Participant Engagement Forum for the Chicago region. Again, we're really glad to have you here. I am excited to be here not only as a staff member of the program, but also as a participant. I participated in the program way back in 2018 before I even thought about the consideration of working with the All of Us program. So I'm very glad I'm here. My name is Kayla Moore. I am Outreach and Engagement Manager at the University of Chicago Institute for Population and Precision Health. And I'm also an engagement and communications lead for the Illinois Precision Medicine Consortium. And that is the group that is over all of us for the Illinois region. We're so glad to have you here today. And what we'd like to do on this event is to make sure that we are engaging in meaningful discussions about data, health, and genetics that are directly impacting your community. So specifically Chicago, that's why we're having this Chicago-specific forum here. We want to hear from local and national leaders and fellow participants of All of Us. So we're going to have different sessions tonight that are for exactly those three things. We're going to learn about the future of All of Us and how you can stay involved as a person involved with the program. And of course, sharing your voice on trust, value, and improving your community and your community's health through research. So with that, I would like to introduce our next speaker for the night, who is Dr. Kareem Watson. He's going to be coming onto camera in a second, but Dr. Kareem Watson is the Chief Engagement and Outreach Officer for the All of Us program, and he's going to give us some welcoming remarks.
Thank you, Kayla, and welcome everyone. Good evening, and so excited to be here. I'm thankful for this opportunity. This is really a dream come true. As we're at the top of the hour, we already have over 440 participants and partners and attendees who have logged on to join. This is amazing, and it's just another example to show that when we put it out there, when we say we want to do this differently, we want to talk about how we are moving forward differently in precision and genomic medicine, we are truly doing this the right way with our amazing partners. I want to thank our partners from the Illinois Precision Medicine Consortium. I want to thank our partners from the office of our CEO, as well as thank our community partners, many of who will be on the call today, who will be on the Zoom today, who have made this possible. I still remember this when it was an idea that we had from our face-to-face where someone leaned over and said, what if we could create a space for our participants to be convened virtually where they could hear all the amazing updates, even hear how their data is being used to advance research. And we could really talk about what we have learned by building one of the world's largest, most diverse data set. So I'm excited to be here, excited to hear all the amazing things that will happen this evening. And thank you for each of you for taking time out of your busy day, your busy schedule to join us this evening. We look forward to having an engaging dialogue. Thank you.
So next, I would like to introduce Erica Zumba, who is Erica Zumba, who is the Community and Participant Engagement Branch Manager for the All of Us program, and she's going to tell us more about our next section, which is our participant panel.
Great. Thank you so much, Aaliyah and Kareem. I'm so excited to be here. I'm also in the Chicago area, a participant, and started with the Illinois Precision Medicine Consortium. So I have the honor of what I said is the coolest panel. I am moderating our participant panel, and this program would not be possible, and we would not be here without each of you. So first, we are going to have two participants as our guests today, and I'm going to introduce them and we'll hear a little bit more about their story. I just wanted to say that sometimes when we are sharing our why and our stories, it could be triggering for some people and have some reminders. So please, take the time, energy that you need, but we're really excited that you're here. So first we have Aaliyah Graham. She's serving as the Vice President of People and Culture and Human Resources for the Reader Institute for Community Journalism, publisher of the Chicago Reader. Aaliyah is skilled in implementing innovative ideas, managing employee performance, overseeing events, fundraising, legal business setup, and leading diversity and inclusion initiatives. Throughout Aaliyah's career, she's found the most rewarding work in breast cancer advocacy and is a survivor of triple-negative breast cancer, which has played a major role of why she's decided to participate. So Aaliyah, take it away and tell us a little bit more about your why.
That is, first off, thank you, all of us, for even allowing me to be here. It's such an honor to be among some really great people and a great program that's doing great things in our community. As you just heard, I have been a triple-negative breast cancer survivor since the year 2020. I was approached by all of us and it hopes to add to, again, the participant enrollment. But the reason that I joined was because I think that this is vital for the African American community, because we are the ones who are dying the most from breast cancer. And that can range from an inability to be diagnosed or improper care. So that's what it actually got me here. I plan on being here as long as they allow me to. And I feel as though this is, again, just vital, just a vital platform so that all communities can be engaged, and so that the research can be done for all communities, and so that things are not so leveled to one organization, to one group of people. All of us is doing great things, and I love being here.
Thank you so much, Alia. And please, for the audience, please feel free to submit your questions in the Q&A, and we'll have the participants answer them throughout. So our second guest today is Balaji Ramanathan. He's a data scientist with broad experience in data analysis, experimentation, optimization, and management of teams of data science professionals. He lives in the Chicago area since 1996 and has a wife and 2 grown children. He has been involved with all of his programs, first as a participant, and then has been part of several advisory committees since 2018. So Balaji, tell us a little bit more about why you decided to join the program.
Thank you, Erica. Nice to be here. As Erica just mentioned, I live in the Chicago area. I've been looking for opportunities to sort of, contribute to the community in any way I can. And all of us has been one of those opportunities that I've decided to take advantage of. As most of you may know, most medical studies are missing samples from minorities. They are often underrepresented in studies and data. And, most medical studies are therefore conducted on pretty narrow demographic samples. So I wanted to, take this opportunity to contribute my diversity to the medical data. So since 2018, when I joined all of us, I have been contributing my electronic health records, my fitness data from trackers and things like that. And in general, I've been also volunteering for, advisory committee meetings and other get-togethers like this to talk about all of us and try to get as many people as possible involved in all of us activities.
Thank you so much. Thank you both. And I'm glad that you said, Aaliyah, that you are going to stay here for as long as we want to keep you, because let me tell you, we want to keep you. And I think we say that for all of our participants as well. But tell us a little bit more about why you've decided to stay, and what you encourage others to think about as they're thinking about if they should be a little bit more active and stay in the program.
I just feel strongly that we are terribly underrepresented, and it's a little scary, especially when you've been diagnosed with some kind of terminal ailment and you don't have the statistical information to back up findings in your community and in your culture. We are very different, although very much the same. However, it's just important to gauge and to identify areas where we can be most beneficial. especially in the medical industry. It's been so one-sided for so long, and then serving in capacities that, excuse me, serving in capacities that don't necessarily fit our culture. Sorry. All of us is bringing us together, and we love them because of it. So yes, I will be here as long as you allow me to.
Thank you. So Audrey, can you talk a little bit more about it? I think what's really interesting is, so Aaliyah is one of our participant ambassadors. That's a formal program. But I think for you, which is great and amazing that you've been able to be in that role. But I think for you, you've been involved in different ways, not necessarily through the formal participant ambassadors program, but you've been part of the community advisory board. You've been part of different boards. So tell us a little bit more about why that has been really important for you.
So as you mentioned before, I am a data scientist myself. I am interested in all kinds of data, even though I don't come from a medical background. Medical data is obviously interesting by itself. When all of us gave me the opportunity to not only come in as a participant, but also guide the program in terms of what the community guidelines should be, what the participant guidelines should be, what the researcher guidelines should be, and things like that. There were several committees that were put together to discuss these things, and I wanted to come in and sort of provide my perspective on those things, coming from a data science perspective, coming from a technician perspective in terms of the technologies that I'm used to, and one of the committees that I participated in was the uh, technology advisory board, uh, which takes advice about how the All of Us app is supposed to work, what kinds of data are supposed to be collected, how they are supposed to be entered, how it's supposed to be made available to researchers and things like that. So it gives me an opportunity to use my expertise in a way that benefits the program and benefits every one of us because of that.
No, thank you for that. No, I think you hit on the head. Having different people with different expertise only makes this such a stronger program. Not only having diverse participation of where we come from, but also of the fields that we're from. So can you give us an example on what our data has helped with so far from your experience? Like, what have you as participants, like what have you learned about our data, the data that we've collected and that participants have provided? So Aaliyah,
Just for myself, some of the things that I learned is genetically, I had no mutations for breast cancer. They are still under the impression that the breast cancer that I contracted was due to stress, which was really alarming to me because I'm like, where did I get it from? My grandmother was diagnosed with breast cancer, but my mom and like my dad have never been exposed to cancer at all. So I learned that just what my genetic makeup is. I also learned some things about my ancestry. I found out that I am 2% Asian, which is amazing because I thought I was just all the way African American, Black, or, so that's been very rewarding to find out. I'm also 26% European, which is baffling to me, but true facts are true facts, and I can appreciate those facts being given to me. I don't know that I would have even sought after any of that information had all of us not approached me about it. So I was very excited to find out that, like I said, I did not have a genetic mutation for breast cancer or cancer of any sort. So with that, I've since learned to manage my stress levels. I changed jobs. I don't let those things that once hindered me physically or mentally, I don't do that. I don't allow people to stress me out anymore because I could not even go through any more cancer treatments. And I hope for the rest of my life, I never have to. So I applaud all of us for giving me that vital information.
Thank you, and congratulations on being able to manage that differently. Balaji, you know, that question came from the audience, from a guest. We have about 30 seconds for if you wanted to share a little bit more about any data that's helped you.
Actually, I would just like to, second what Adia said. I don't actually have anything to add to it. I was also, pleasantly surprised, or rather, happy with my genetic data and so on. But in general, I hope my data helps others rather than just helping me. That is my sincere hope with sharing my data with all of us.
Thank you both. Thank you so much. We're so honored and privileged to have you here. And you know, I think you said it, Balaji, like it's not just for us, it's bigger than us, right? So with that, we are going to everyone give you a virtual hand. Thank you so much. And I'm going to hand it off to a wonderful next presenter, Adriana Mares. And I'll let her take it away. Thank you.
Thank you, Erica. I am Adriana Mares, and All of Us participant ambassador and advisory committee for the All of Us Scholars. And I've been fortunate enough to access and use the All of Us Researcher Workbench to conduct studies on cardiovascular disease. And most recently, I've had the honor to receive a grant to specifically study Hispanics participants who have enrolled in the All of Us and the sleep disorders and, again, cardiovascular disease. And today I'm just so excited to moderate this session that focuses on research, specifically on the research that has been done with the All of Us data. And we will be hearing from 4 wonderful researchers who have done research with the All of Us data to address health disparities in populated areas. We'll first hear from Dr. Brisa Ashbrook-Kilfoy and Dr. Andy Craver. Dr. Ashbrook is an associate professor of family medicine and public health at the University of Chicago. She's a chronic disease and environmental epidemiologist whose work focuses on health disparities. She is an MPI on the AOURP, serving as an investigator in the Illinois Precision Medicine Consortium since the All of Us launch. Her team has done extensive community-based enrollment on mobile medical units, ensuring inclusion of underrepresented communities. And she is a contact PI at the University of Chicago for the Nutrition Precision Health Program. She serves on the AOU Environmental Working Group and is very excited to support the enhancement of environmental data in the All of Us. Our second speaker is Dr. Andy Craver, who is the research specialist at the University of Chicago Institute for Population and Precision Health, where he works on data management and analyses for the Chicago Multi-Ethnic Prevention and Surveillance Study, also known as COMPASS, and the All of Us Research Program. He also manages the NIEHS UP on EHS Fellowship for undergraduates from backgrounds historically underrepresented in the environmental health sciences. He is the All of Us Research Workbench Laboratory Lead for the U Chicago Masters of Science program and teaches data management and analyses using the workbench to students, staff, and faculty. We're very happy to have you here, Dr. Craver and Dr. Ashbrook. I look forward to your presentation.
Great. Thanks so much for the kind introduction, Adriana, as well as the invitation to present our work at the University of Chicago. I have a funded grant to do research on the environment using All of Us data with the analyst, but Andy and I also do work with undergraduates in my Up on EHS training program, Masters in Precision Health students, as well as postdocs and faculty who are interested in using the data for various research questions. In the past few years, we've published an article on cancer in All of Us. We published a follow-up article looking specifically at the impact of air pollution on cancer risk. And this past year, we compared community and individual level variables when we were thinking about the impact of air pollution on cardiovascular disease risk. We actually found that contextual deprivation was more significant than individual level factors, a very important finding for people wanting to make change. This suggests that community level interventions could be as important or even more important than individual level prevention interventions. And we will, of course, continue to follow up on these findings. You can move to the next slide. Participant data was critical to do this research project. We leveraged electronic medical records to look at cancer diagnoses as well as incident cardiovascular disease outcomes, meaning events that occurred after participants enrolled in the All of Us research program. We used participant residential data at baseline or part of participant zip code to assign pollution exposure metrics. And we used lots of individual data provided in the surveys like age, sex at birth, smoking, and race and ethnicity for these projects. The scale and the diversity of the data provided by the All of Us participants has enabled us to report on findings for the first time, to improve the approach, and to look at the impact on specific groups. My team is really focused on looking at the impact of environmental injustice and racial disparities. So the All of Us Researcher Workbench is a very powerful and important tool for my work and my trainees. You can go to the next slide. In this map, you can see the air pollution distribution that we assigned to All of Us research program participants. Yellow means highly polluted outdoor air, and green means less polluted outdoor air. We group participants into these categories for analyses, and we compare disease risk in those who live in highly polluted areas to those who live in less polluted areas. The red dots show where the HPO sites are located nationally. The increase in risk in female cancers, including breast cancer, endometrial cancer, and ovarian cancer, are a new finding for the United States. There was one previous report in a large study in China, but the levels of pollution in that project were much higher. We'll be following up on this work in future studies. As a scientist, but also an All of Us participant and a mom to 3 little girls, I'm glad to see that more knowledge on the environment and cancer and cardiovascular disease is supported by this program and the robust and diverse data collected. I'm now going to turn it over to Andy Craver to show you how the data browser can be accessed to explore your specific research questions.
Hi, everybody. Not a doctor. I just wanted to clear that up to begin with. But I do use the All of Us Workbench a lot every day, and I love using it. So for most folks can't use the data browser or the Workbench itself, but you can use the data browser to get a high-level overview of the health conditions and some of the survey responses that are in the All of Us data set. So if you look up just All of Us Research Program Data Browser, or if you go to this URL or use this QR code, you can see those data. I'm going to share my screen to kind of give you a quick walkthrough, and we'll look at a condition, right? So you can go to databrowser.researchallofus.org and look at explore the data on your own. You can't explore row level data, so you won't be able to find your own data. Of course, which, for reasons of confidentiality, you wouldn't want to do anyway. And, we're kind of forbidden from doing that as Research Workbench users. But you can explore health conditions across various domains. So EHR, electronic health records, these are very crucial to this program because this is where most of the data come from. And you can see that, there are about 250,000 people with EHR in the data set so far. And then also, actually, let's see overall. Yeah, about 250,000 participants with EHR data so far. And you can scroll through and get a feel for genomics, measurements, and survey responses. So if we look at a condition, I typed in diabetes, which is a very popular condition to look at. You can find this across a number of domains. We'll look at conditions here. So diabetes, and you can see your overview stats for diabetes. So there's over 55,000 participants with diabetes in their electronic health record. In all of us, there's 56,240. And there's all these constituent conditions and kind of complementary conditions that go into this one umbrella condition, diabetes mellitus, right? And you can use this little kind of hierarchy umbrella to look at the conditions that make up that parent condition here. And you can see the number of cases there are for each. And then you can explore it here a little bit. So sex assigned at birth and age of the participant with that condition. So it's a pretty high level overview, but there are a lot of there's a lot of possibility here in order to get a sense of the data. And anybody can do this at any time. And it's kind of interesting to explore, right? You can see, when diabetes is a response in the personal and family health history questionnaire, you can see the questions and the responses. So see answers, and you can kind of explore it that way. Let's see. So the data browser, is a really great tool to use for this kind of exploration. If you wanted to find really like any other, if we look at COVID-19, check that out too. Ooh, is it going to come up? Yeah, condition, procedure, drug exposure. Let's see if there are any drug exposures related to COVID. Yeah, vaccination, right? So you can explore vaccination trends in COVID. So we have 31,340 participants with a vaccination record in their All of Us data. So yeah, this is a super helpful tool. I recommend that all of you explore it and get to know it. There's also some other there's some other tools here, and have fun with it.
Thank you, Andy, for that walkthrough, and Dr. Ashbrook for sharing with us a bit about your research. Our next speaker is Dr. Yvonne Collins. Dr. Collins is a gynecologic oncologist and current chief medical officer at County Care within the Cook County Health Hospital System. She has devoted her career to educating underserved women on the importance of routine health maintenance, including Pap tests. Her interest includes community outreach and education on the causes, prevention, screening, and early detection of cervical cancer, which is preventable. She also has an interest in empowering women through education, eliminating barriers to care, and increasing access. Lastly, she is a member of Delta Sigma Theta and serves as the Chicago citywide coordinator for the Delta Research and Educational Foundation Research Matters for the All of Us. Thank you for joining us, Dr. Collins, and we look forward to your presentation.
Thank you so much, Adriana. Good evening, everyone. Thank you so much for joining us. And I'd like to commend our participants, as you are 839,000 strong who've decided to move us toward that goal of 1 million participants. Next slide. The Delta Research and Educational Foundation is a 501c3 organization established by Delta Sigma Theta Sorority Incorporated in 1967. Our goals are to promote research and identify solutions that affect the African American population and eliminate healthcare disparities. We do that through creating awareness, encouraging health and wellness, and educating the African American community, which is our focus for the All of Us project. Next slide. We do that through an array of ways. We have our HBCU outreach and engagement. You can see the statistics there. But we believe wholeheartedly that in order for us to move the needle on clinical research, especially in in communities of color, we have to have researchers that look like those participants. And so we do that through that program. Next slide. We focus on our cities next. And as the Chicago Citywide Coordinator, I work diligently each and every day to identify disparities that are prevalent in the Chicagoland area, outreach to communities that are impacted, engage with community organizations that have found solutions, and work closely with our healthcare provider organizations to ensure that as we identify participants, we can enroll them in All of Us. I work closely with the University of Chicago, the University of Illinois, Rush Medical Center, and Northwestern. Together, we have done multiple community events in Chicago. We have engaged participants and educated them on the Research Matters for All of Us campaign. We've had pop-up clinics where we're able to diagnose early stage kidney disease and intervene. We've had pop-up clinics where we've worked with institutions to educate them on the importance of precision medicine related to colorectal cancer, related to breast cancer. We've done clinics where we have been able to vaccinate communities where there was vaccine hesitancy. And we continue to partner with the trusted voices in the community, because when we look at research, we know that populations of color especially look at trusted voices. Those trusted voices in Chicago have been many faith-based organizations, and we continue to look at ways for us to outreach those communities. Next slide. We do our last proponent of work through our 22 researcher working group. You've heard from some researchers today, but our researchers locally have began to look at healthcare disparities related to an array of diseases. We host lunch and learns in order to sort of have a more intimate conversation around healthcare disparities and how the All of Us Project will work to eliminate those healthcare disparities. So I thank you for partnering with us. I thank you for being more than 67,000 participants here in Illinois that have focused and helped us move the needle on doing research here in Chicago. And I will turn it back over to Adriana. Thank you again for your participation.
Thank you, Dr. Collins, and congratulations to you and your team. I love the collaboration and teamwork that you all have, been able to build over the years. Just so amazing to see. Our last speaker for tonight is Dr. Jason Carnes. Dr. Carnes also serves as the Director of Scientific Programs for the University of Arizona Banner All of Us Research Program, and also serves as the department head for the Department of Pharmacy Practice and Science at the R. Ken Coit College of Pharmacy at the University of Arizona. Dr. Carnes' primary area of research interest is predicting side effects and responses to drugs. He employs a translational approach to investigating pharmacogenomics associations using observational studies, functional genomics techniques, and eventually clinical trials. His ultimate career goal is to facilitate personalized cardiovascular medicine and genotype guiding prescribing to avoid serious drug toxicities. He has received support for his research from the American Heart Association, the Flynn Foundation, and the American College of Clinical Pharmacy, and the NIH. Thank you, Dr. Carnes, for being with us, and we look forward to your presentation.
And thank you, Adriana, for that wonderful introduction and being able to wade through all that scientific jargon. So yeah, no, I'm very glad to be here and engage with potential participants for the All of Us Research Program. So I'm Jason. I'm a pharmacist by training, and so I'm really very much interested in creating more safety and more effectiveness for our drug treatments. If you would advance to the next slide. You're probably somewhat aware that historically our standard approach to drug treatment has been a one-size-fits-all kind of approach. And that's really represented by the left side of this figure here, where, regardless of people's genetic background or their personal characteristics, their walks of life, pretty much everybody is given the same starting drug at the same starting dose. There are, of course, exceptions to this, but this is by and large what we do clinically these days. And what we're really trying to get to, and all of us is a big part of this, is a more precision medicine approach. And what I mean by that is using people's personal characteristics to guide drug treatment, to get the right drug at the right dose to the right person at the right time. Right. And so there's a number of things we can use. We can use people's characteristics like their sex or their weight. But we can also we're being able to start using genetics and variation in people's genetics in order to determine whether someone is going to get a major clinically important side effect or whether someone's going to respond to the drug. And that way, we're not just giving everybody the same dose, the same drug, and then hoping for the best in this trial and error approach, but we're using these factors to predetermine who's going to benefit most from these drugs. And if you'd move to the next slide, it's really, this is one of the most important pieces, and really the first step in being able to make this happen is the diversity, right? So historically, in our genetic research, people with European ancestry are by far the most common group, and that's reflected in this chart here. On the left side, you can see the amount of data produced in genetic studies, and it's highly European ancestry. You see the red portion of that graph. It's mostly people who would describe themselves as white. But that's only 12% of the world population. And you just think about all the genomic diversity that we aren't capturing as a result of that discrepancy. Not only are we not representing these patients, but it's bad science because we are not taking advantage of all of that diversity that exists outside of this European ancestry population. And so this is one of the critical focuses of all of us and why we need diversity in our studies. Next slide, please. And here's a big reason why. On the left side, you can see a similar pie chart where it's the number of individuals, again, mostly European ancestry individuals. But if you look at the associations, or rather what I would term this as is discoveries, you make more discoveries, disproportionately more discoveries when you look outside of European ancestry individuals. So if you start incorporating Hispanic and Latino participants, African-American participants, and all the great diversity that we have within the United States, the science is aided because you can now make more discoveries because essentially that genomic variability that you were ignoring before is now a part of your more representative sample. Next slide, please. Now, that being said, we always have to think about differences between racial and ethnic diversity versus ancestry, right? Ancestry is biological, it's genetic, it can be determined in a lab, whereas racial and ethnic diversity is self-reported. This is a sense of personal identity, right? And these are distinct, these are sometimes aligned, but not always, right? And one of the other great things about all of us is it allows participants to report some of those factors, some of those social factors that also have largely been ignored in classical studies. And we're talking about things like access to care and geographic location and more social determinants of health that may have an influence on disease that we typically ignore because we're more focused on the biology. But moving forward, all of us is doing a great job at putting all of that data in the same place so that we can start to disentangle the biological causes of disease versus the social and structural causes of disease. Next slide. And again, in terms of precision medicine, right? So this is a big focus of the program. This is the medicine in your DNA report. So how do genetic changes that are specific to you, how does that influence response to medications and whether you could actually be treated with these medications without risking this major side effect? And on the right side here, you can see that 96% of the individuals, and this is globally, 96% of people have some kind of a mutation in their genome that indicates that they need some different treatment or some different dose. And that's the pharmacogenomics term that got mentioned earlier. This is the medicine in your DNA report. By increasing that diversity, we can make more of these discoveries. We can fine-tune our treatment even better than we've been able to do so far. And I thank everyone for their attention and look forward to answering any questions you might have.
Thank you, Dr. Carnes. Really appreciate how you emphasize that diversity and how that makes the All of Us so different from other programs happening worldwide. And now I'd like to turn the last few minutes of this session to an open discussion to questions that have been submitted to us in the chat. And also, if you have questions that you would like us to answer live, we also encourage those of you to please raise your hand by selecting the raise hand function at the bottom of your screen. So the first question that we have in the chat is from one of our participant guests, and it's not directed to any of our panelists, to whoever wants to answer this question. So the question goes, how can I use this information to inform my healthcare? Anyone who would like to take this question from our panelists?
So I can jump in terms of the return of results for the medicine in your DNA report. So that last slide I showed had 7 different genes in it. That is a part of what the return of results for all of us is. And these include several drug metabolizing genes. And these are all genes that have an influence on either drug response or your risk for an adverse drug reaction. So by participating, when you receive the return of results for the medicine in your DNA report, that can inform whether drugs are appropriate. Given the advice of a provider and a physician, it can inform whether or not this is the right drug for you or the right dose for you, just based on that one report.
What I add to that, if you continue to look at this slide, the health-related genetics and hereditary disease risk allows you to identify potentially diseases that you may be at risk for from a hereditary perspective. If those are common diseases and we have a screening modality for it, you're then able to hopefully screen for that disease prior to diagnosis. And so earlier screening hopefully leads to early diagnosis, which leads to better treatment for most diseases.
Thank you. And again, we invite everyone who is joining us at this webinar to, if you have a question that you would like to answer live, please do raise your hand and we'll do our best to unmute you. Our next question is again for any of our panelists. Our guest participant is asking if the results from, for example, in your research that you've done with the All of Us, is it through the blood that was provided when they registered to the program?
Oh, I can say that so far we have not used those data. We've only used I mean, we haven't done much genomic work. We've just used EHR data, so electronic health record data, and then survey data. And I forgot to mention, this is another great reason to remain to join All of Us and then to remain retain or remain active with the program, is to complete follow-up surveys and really contribute to those longitudinal data points, those data points over time, and then also to fill in the gaps. We have some surveys that just don't have that many respondents. They might have only 10,000 respondents in the Chicago area, but so far, yeah, we've only used the EHR data and the survey data.
So I can jump in. Our laboratory and many of our collaborators have used the genetic data extensively. And when you think about just the size, 250,000, 250,000 whole genomes, it's a resource that really is unparalleled, with the possible exception of UK Biobank. The issue with UK Biobank is that it is not a very diverse sample. I mean, coming from the British Isles, it's again primarily European ancestry individuals. Because of that diversity, combined with just the size, the sheer numbers, we can start to study even rare expressions of this variability. An example with the medicine in your DNA report is, we're identifying individuals that have a genetic background that we've never seen before, right? And when there's 250,000 diverse individuals, that's really not that surprising. And so we're starting to fill in many of the gaps that have pre-existed, that have predated the All of Us research program.
And I'll add, that's why diversity is really important for this particular project. When you look at clinical trials overall, about 11% are Hispanic, 8% are Black, 6% are Asian. So when you're looking at other databases that have been created, there is not that diversity. And so with the All of Us Research Data Bank, you're able really to get a better spectrum of the population because everybody may not respond the same way to various treatments and or drugs.
Thank you to our panelists for answering those questions, and we're loving the interaction from the attendees tonight. We please, if you have any additional questions, continue adding them on the chat. I would like to take this opportunity to invite participant 1 to unmute if you feel comfortable. And I see you have unmuted. You may ask your question. We might not be hearing you, so what we could do is circle back to you, and we could go to the next question that we have in the chat. This question is specifically to Dr. Carnes. How did you go about conducting your genetics research in terms of methodology?
Sure. Well, I mean, the availability of so many different types of data sort of opens the floodgates in terms of what you can do. Historically, we've done study approaches such as genome-wide association studies, or GWAS, and what these can really do is help pin down whatever the genetic association or the genetic cause of really any disease or drug response that you're able to look at. The cool thing about All of Us is, again, that diversity, and you're doing this in a population where it's never been done before. And so because there's new variability, there's really the potential to make new discoveries. We've also used phenome-wide association study approaches, or PheWAS. And what these do, they're similar, except they look at a single genetic variant, and then they look at across the whole electronic health record, what are the diseases or the conditions that are associated with that genetic variant. And so this can elucidate new roles of a particular gene or a particular variant in different types of disease, and also look at something called pleiotropy, which is the contribution of one genetic variant to multiple different diseases through independent pathways. So those are some of the most common approaches that we've taken.
Thank you, Dr. Carnes. And we continue to get participants who are just ready to ask live questions. So we are now seeing that participant 2, we have a question. So please feel free to ask your question if you're ready.
If there's an institution that you're currently participating with, you should be able to call that institution to get assistance. The other option is if you want to put your name in the Q&A, and we can make sure that and where you're located, and we can make sure we have somebody reach out to you.
Also, for anyone who may also have a similar issue, you can always email the All of Us team at help@joinallofus.org, or you can call their support center at 844-842-2855. We'll also add this information in the chat. And but great question. Thank you, participant, and all the participants who have been willing to put their questions and come off mute. Our next question deals with how can we partner with Delta and DREF on any future events at a local level, and is there a person we can contact directly?
Yay, absolutely. That would be me. I will put my information also in the chat, and please feel free to reach out. We're always looking to partner on the local level.
Thank you very much to our panelists, Dr. Carnes, Dr. Collins, Dr. Ashbrook, and Andy for your wonderful presentations. And again, to everyone who have submitted their questions in the chat and those who have been willing to come off mute and ask their questions live. So this concludes this session. And lastly, we just want to hear from everyone joining us tonight. And we would appreciate if you all please write in the Q&A box on the type of research that you would like to see more of with the All of Us data.
Welcome, everybody. Good evening. As Angelica said, my name is Deidre Tillery, and I am a program analyst with the All of Us Research Program. And I'm thrilled to moderate this evening's panel on program updates and discussions with both Drs. Kareem Watson and Josh Denny. And to introduce him briefly, Dr. Denny is the Chief Executive Officer for the All of Us Research Program. He's not only a practicing physician and accomplished researcher, but he has also been a pivotal part of this program since its inception, even before it was officially announced by President Barack Obama. He has published more than 400 papers, focusing mostly on discovery and implementation projects in precision medicine. And Dr. Denny will start us off with a brief presentation highlighting the latest program updates. And after that, we will dive into a discussion with Dr. Watson and Dr. Denny, followed by a Q&A session with our audience as time allows. So, Dr. Denny, the virtual room is yours.
Thank you so much, Deidre. It is a real pleasure to be with you today. And I just thank all the wonderful presenters that have come before me. We're excited to be doing these kinds of virtual presentations, and Chicagoland area, Illinois Precision Medicine Consortium to be the first to host us with this kind of venture. Go ahead and go to the next slide. So Deidre gave my more academic intro, but I want to give a little bit more of a personal intro. And on the right is a picture of my grandmother, my great-grandmother, and my uncle, the taller, and then my dad up front with maybe a slightly mischievous grin on his face, staring at the camera. But what you don't see here are there are 4 people that are not in this picture. My grandparents lost 4 children to cystic fibrosis, a rare genetic disease that you have to inherit 2 copies of a defective gene called CFTR. And at the time, there was really no treatment. All those children died as infants. And I grew up with those stories. My dad remembers taking some of those kids to the hospital for the last time. And what we have found through precision medicine is an incredible way to counteract those changes. It started when I was a resident and medical student, just better specific treatments for infections that these kids got. It's a terrible disease that affects your lungs, your pancreas, and so many other organ systems. And but in 2013, we got a specific drug that targeted just 5% of the population with cystic fibrosis that could, for the first time, see their lung function improve and start to correct that deficit. And in 2019, through precision medicine, 3 drug combos have dramatically changed people's lives with cystic fibrosis. For more than 90% of the population, you can reverse this disease. And so individuals that used to die as infants in the 1950s now can expect to, if born today, live a long, healthy life. And we are seeing much a greater improvement with this condition. And so we want to see this kind of change writ large across medicine. It's many rare diseases, but it's also common diseases. Dr. Carnes talked about some drugs don't work the way they're supposed to, that a lot of us take, and we can get better at that. And our program is helping to do that. Next slide. I want to talk a little bit about where we are now. So thanks to you, it was mentioned earlier, more than about 840,000 people of you have signed up, more than 46,000 in the Chicago area. And really, because of you, because of all of our partners like DREF and so many others, we have been able to just really achieve the kind of diversity that we haven't seen in any other kind of study in the United States or worldwide, with more than 85% identifying as populations underrepresented by medical research, more than 46% underrepresented by race and ethnicity. And this just isn't in any genetic study. It isn't in any clinical study. The discoveries come from you all. It's together that we do this. Researcher access is really important. How we do this in a safe and secure way to derive science that preserves confidentiality and the de-identification of your data, so they don't know who you are, but they can do that kind of study within our data resource and do it faster, safer, and better than what's happening traditionally. We have more than 13,000 researchers, including more than 300 from Chicago, and we really tried to make this an on-ramp for researchers to become involved and make discoveries that wouldn't typically be able to do this kind of research. You don't have to have a high-tech computing facility that costs millions of dollars at your institution to do it. You can use ours. So that's helped us get people at minority-serving institutions, historically Black colleges, universities, Hispanic-serving institutions, and even young trainees the opportunity to come in and do science and ask questions, because asking more questions helps us lead to better science that affects more people. Next slide. What kinds of data? You as participants know this well. No matter how you come into the program, people contribute the same kind of information. Most of you probably enrolled through a physical medical center, a healthcare provider organization, but a lot of people just sign up also by finding the website and signing up. That's how I signed up from when I was in Nashville, because we didn't have a healthcare provider organization. I now live in the DC area, but have an uncle that lives in the Chicago area. And from participants, you fill these surveys out. We ask surveys the kinds of questions that we don't get from like electronic medical records, things like social determinants of health. So we know about your environment and the important influences those kinds of things have on your health. We also are able to ask questions like mental health and well-being. That's so important that we know about. And then to researchers, the researcher data set, as we pull it together and process it, it's smaller than the number of people who sign up. You remember that over 830,000 people have signed up to participants. Our researcher data set that we've curated and de-identified, it's a little over 400,000 to researchers now. And we're working on our next release that will really increase that size quite a bit more. About 50% more people will be in that next release, and we'll add a little bit more than that in the terms of the number of people that have genomics. That 250,000 of you that we've already made genomic data available to research is just a huge number. In this one data set, we probably have more diverse genomes than maybe the rest of those data sets and the rest of the world combined. And that is so important because it will, lead to those kinds of discoveries that we will only find, like Dr. Carnes talked about, with diverse populations. And then we have things like Fitbit records. We're going to dramatically increase that number of data available for research, and thinking about, how does sleep affect health? How many steps you take a day affect health? And can we, prevent diabetes maybe by doing those kinds of interventions and helping encouraging that? We don't always need drugs sometimes, and that would be healthy and lead to better health. And then we want to return information back to participants. It's things like surveys, data, stuff like that, but it's really importantly, reports of our scientific findings and DNA results. Go ahead and go to the next slide. So just to talk about some of the things we did, one of the earliest studies we did was we worked with some of the other investigators across the NIH in 2020 as COVID was just happening, to look at people that developed donated blood samples from January to March 2020. You may remember we only knew of a handful of cases in the country, less than 20 by the early part of March in the country at this time. And people wondered, was the disease already here and we didn't know it? Well, we were able to test our samples and show that, including 5 cases in Illinois that happened and before we actually knew about them being there. And so it's evidence, the data that you provided is evidence that we had some community spread of COVID before we were recognizing at the time. And it's real translation of impact. We also allowed people, it was only those people that enrolled in January through March of 2020, we allowed them to get their results of their COVID testing if they wanted to know that at the time. And then in 2022, we started our first results for genetic health-related results. And since then, we have returned genetic health-related results, about 240,000 individual reports to that. And over 200,000 people have looked at either genetic ancestry or traits. The scale of genetic health report return here is at a scale of way beyond any other research study that I know about in the world. And at times we've been able to do up to about offer 5,000 people a week those results. But if you're one of those 15% of people that haven't gotten those results yet back, know that we're working on it, and we're actually working on a way to close that gap faster in 2025. So if you haven't gotten your results back yet, know that we're working on closing that gap, because if you're one of the 15%, it doesn't matter if you're the 85% that have already gotten them, that want them. I understand that. But the important thing about doing this is, we have over 3,000 people that have learned about potentially life-changing results from that, and over 100,000 that have learned something about a medication that would need to be different given their genetics if they were prescribed that medicine. So, these are real health impacts, and those with those 3,000 life-changing variants, those are the kinds of changes that you can do something about. If you find you have one of those genetic variants, there's something different you can do to lessen that risk. We've talked a lot about the importance of the diversity of the population we have, and that you're contributing, and what that means for discovery. And so we are now, as we process and interpret these genomes for health-related impacts, we have found more than 7,000 genetic variants that we have gone through our evidence generation process to figure out whether that genetic variant makes a difference or not for these diseases or drug response. And then we have returned those genetic variants. It's not related to a person. It just says this spelling error in this gene is related to a disease or not. And then that becomes available for another doctor, maybe not even part of this program, when they see a patient, and they can look that up and say, oh gosh, this genetic variant makes a difference or not. And it already makes us one of the top 20 clinical labs in the world in terms of the amount of genetic data that we have interpreted and made available to people, so that the whole community gets smarter. So they don't just say, gosh, I don't know what this genotype is. They have a prior reference. And then the last thing here that's mentioned is amongst other kinds of surveys we do, one of them is mental health and well-being. And part of this survey, you can get access to personality trait information afterwards. It's just another example that we try to do things, if we can, interesting from this kinds of tests and surveys that you all complete, to try to give you something back. Next slide. This is just an example of some of the different papers that have been published on the resource. What we're doing here is, these are snippets of what we call research highlights. So hopefully you've been noticing the emails and newsletters we send out. And so we send these out to newsletters to you all. It's also available on our website, so you can read more about any of these things. And there's a QR code for one of them if you want to read about. And this is an example of one of those stories of how your DNA could affect, in this case, processing of certain cancer drugs, and a genetic variant and an effect that's been changed because of an understanding that's grown because of all of us data. On the right is just one example here of an kind of condition that just points and highlights the importance of the diversity of our population. We know that African Americans are at increased risk of kidney disease. And actually, most of that increased risk of kidney disease, about 70% of that increased risk, is due to having 2 copies of a genetic variant in a drug called a gene called APOL1. And so this paper actually shows ways, by looking at that gene in our large population and combined with a couple other populations, allows us to understand that there's some other spelling variants in that gene that may help reverse that risk. And it points to a way that we can actually intervene on that kidney risk and lessen that risk, so that it won't be, cause kidney damage and risk of kidney failure. And so we hope that this kind of study is one that points to ways to decrease that risk and provide treatments for that condition. Next slide. We are constantly thinking of how we, what's next for the program, how we improve. We have some changes you may have heard about, and you'll hear more about in the coming months, where we're going to change our website that you'll log into. And so there's going to be a different interface. At least for a while, that means if you use the apps, those apps won't be there, but you can use the websites on any phone or computer, tablet. They'll be responsive. And one of the reasons we're doing this is we're going to be able to support you better with this. We'll be able to reach to different technologies implemented through here. We'll be able to do things in a cheaper way. And this will be coming, and you'll hear about this as we transition from 24 to 2025. In addition, we've had a bunch of really exciting developments and partnerships with other institutes and centers across the NIH. So the NIH is this big research enterprise, and they're seeing the real value of all of us, what you've done here. And so one of the big ones here is Nutrition for Precision Health. And that's an important study which has involvement from Chicago. And it is looking at the biggest study and the really deepest study about how nutrition affects our health, using genetics, using understanding of the bacteria that live in our gut and other components like that. We hope that we'll be able to really figure out how diet affects health, and maybe actually can we tailor a diet just to you? What's going to help your health in that? And then we're looking at causes of people who develop diabetes. We know a lot of genetic causes of diabetes, but we don't really understand well the environmental causes. And maybe there are environmental causes. So we are partnering with another part of the NIH to study those in a comprehensive way. And then we're studying eye health. And that eye health study is being done with Chicago as one of the sites as well. And we'll be looking at pictures of the eye and correlating that not just with eye disease, but can we get predictors of heart disease or dementia, other conditions like that. And finally, we're very excited about thinking beyond this generation, but to the next generations, and how we start with pediatrics and enrolling children. And so we have started rolling in a few test sites, 5 sites across the country, children 0 to 4 years old. And that's a picture of the foot of our first pediatric participant in the program. We're very excited for that to be part of our future. So it will truly be all age ranges across the program. Next slide. And so with that, I just want to say thank you to you for being parts of the program and really making this happen. I mentioned I'm a participant. I mentioned pediatrics. You can see my daughter there. I'm looking forward to the day she will be able to join the program, hopefully soon.
Great. Thank you so much, Josh, for that update. I appreciate that. And we welcome back Dr. Watson onto the screen. And while the presentation was going on, we did get quite a few questions into the chat. So let's go for it. So the first one is going to be for Dr. Watson. So Kareem, as a health disparities researcher, why is it critical that all of us participants continue to enroll and stay engaged with ongoing research opportunities? And how does this engagement shape the future of precision medicine?
That is a great question. Deidre, can you hear me okay?
I can, yes.
That is a great question. I first want to start off by answering that question by a question I get from my own family. Some of my family still don't know what I do for a living, so I have to tell them on a regular basis. Sometimes they'll say, you keep talking about we know you work at the NIH, and they only kind of connect my job at the NIH to, oh, did I freeze? Oh, okay. They only kind of connect my job at the NIH to Dr. Fauci. So I have to first say, shout out to Dr. Fauci and all the amazing work he did. And so I have to tell them where I work first, right? I work at the NIH. And then they're like, okay, you keep saying precision medicine, but what is that? So then I break it down and I tell them, I say, we often say it's not a one size fits all approach. And I use a common example of things like our glasses. These are actually readers. They're not prescription, but they're 1.5. So they multiply things when I see them. And I tell my family, so imagine the preciseness that we have, the way that your glasses, or in my case, my contacts plus my readers, the way that my contacts are made just for me based on my eye vision. That's a very precision way of approaching vision care, right? But as Dr. Karn said in his presentation, medications aren't always that way. So we haven't always had that approach to thinking about medications. Many of us go to the doctor and we go over the counter and we buy a medication. And I think that will always be the case. There'll always be some medications that we'll take over the counter that will be kind of like for all, and we'll know how to take a little bit or whatever, right? But then there's some things that we need to take a deeper look at. And when I think about precision medicine, I tell my patients, I work for my family. I work for the NIH, and we are doing a study that is in precision medicine, where we're trying to understand the way someone's genes, the things you inherit from your parents, what you inherit from your parents, your DNA, interacts with environment. We kept using that word a lot today, environment. And by environment, we mean where you live, what air you breathe, what you take in, whether it's fumes or toxins, or even the amount of fresh trees in the space where you live, your environment, and even your lifestyle. Like our Fitbit studies telling us how many steps we take a day. Like I'm constantly watching my watch because I want to make sure almost 10,000 steps in, or so many more steps, because we did an amazing study that shows that the amount of steps you take can inform how healthy you are. So that's what precision medicine is. It's really taking into account all those things: your DNA, which is the biology, your lifestyle, what you're exposed to, and the environment and what you do. So that's what we think about precision medicine. And then when I think about this concept of variants that Dr. Denny was talking about, this mutation, when I was in school learning about DNA mutations and everything, we use the term mutations a lot, because I like to think of DNA sequence kind of like as like a word spelled out. And like these words, the way they sat meant something different. A variant is when that spelling of that word changes. And we use the term variant now more than we use mutation, because sometimes that change is not always bad. But when I was in school, we use the term mutation. And when you hear the word mutant, you're like, oh, that sounds really bad. I start thinking of cartoons. But now we think about that change. So now let me get at the question, Deidre. Why do people need to complete the surveys? Well, as a health disparities researcher, I saw someone put in the chat that imagine if we can look in time and say that when you first enroll in All of Us, you may not have had cancer. You may not have had a disability. You may not have had a particular health condition. But 5 years later, after enrolling in All of Us, and you complete a new survey, you say, I now have cancer. I now have diabetes, or I now have a chronic disability. We're able to look and compare and see, why did you get that cancer? What age did you get it? What changes happened? Because there's so much information we can know by looking at patterns over a period of time. I'll end it by saying, Deidre, I was talking to one researcher who looks at HIV research, who wanted to say, can I look at the EHR, Kareem, or someone in your data set who may have a diagnosis of HIV or AIDS? And I said, yes. And they said, can I look at how their renal labs may change over time? I said, you can, if we keep getting access to that person's data, and if we keep having the resources to put out new data. So I'll stop there because I've taken a long time to answer those questions.
Well, thank you for that answer. So there was actually a little bit more to that question too, just about the diversity piece of that, because also given the diversity is the most important mission we're on, how do participants who are not part of the sector, not part of the a specific ethnic group, how are they helpful to the program?
Well, we love to say, and I would love for Dr. Denny to also comment on this,
Yes.
we love to say diversity beyond self-identified race and ethnicity, right? Because even amongst our participants in Illinois, for example, who self-identify as white race or ethnicity, they still are part, many of them are part of, more than 50% of them are part of other groups that are underrepresented in biomedical research, meaning by age. Research historically has been done on people that are younger and healthier. So we know our population, about 1 in 4 of our participants is over the age of 65. Population living with a disability is often not included in research. 1 in 5 of our participants are living with a disability. Sexual and gender minority, populations who self-identify as gay, lesbian, transgender, straight, or bisexual, transgender, plus those communities are often not included. Even rurality, like where you live. So when we think about the importance, so that's why everybody's information is needed. I'm going to say it's going to be a pun, Deidre, but all of our data, all of us, is truly needed to really understand diversity, equity, inclusion.
The name is the mission. I love it.
Name is the mission.
Yeah. So let's get Josh in here because one of the questions that came up is what's been the biggest challenge in running the study, and what's been the most fascinating discovery so far? So I'll throw out to Josh.
Wow, great questions. There are lots of challenges. One of the things is just pulling together across the country a truly national study. And so I don't know of any other study that tried to really do that and wanted to be inclusive and really authentically communicate with diverse communities across the country. And even just getting all these different healthcare systems to work together on one project is not something that the NIH typically does with research studies like this. And we've been able to do that, to pull all those electronic health records together across many different vendor systems. And really, we're the first ones to do that in a national study, or any kind of study, to put that together in a harmonized way that researchers can use in an easy way. We develop new technologies and approaches to get that data safely to researchers in ways that preserves privacy, and then them working within our resource, which makes it faster, better, and safer, we think, all at the same time. And then obviously the engagement work really that led before we enrolled anybody, going to 17 cities. Kareem led those in Chicago, asking questions about, what's valuable to you, and how do we, what does precision medicine mean, and how should we even name our study? Asking about those kinds of things, to really find something that would be impactful. In terms of what we're finding, it's hard to name any one thing. It's basically, there's at least a paper coming out every day now. We're really in an inflection point of researchers being able to use and find things. One of the things that's most exciting to me is, as I've been involved in lots of different research projects outside of All of Us before this started, and a lot of times there's just a lot of researchers, there just isn't the numbers of people across things like people with disabilities, or different race or ethnic populations, or people that live in rural populations. There're just not enough people there to actually support a statistical analysis and make a conclusion. But you see that pretty much every study here is able to include diverse populations because we're so big. And so that means you're seeing your first studies really looking at all these kinds of variables in ways that are so important. I mentioned the study about that APOL1 kidney disease is something I'm particularly, I think is really important, because, it is such an important aspect of kidney disease is such a tremendous health disparity. And it is something that if we figure out a treatment for this, just like cystic fibrosis, that could mean the difference between needing a kidney transplant and being on dialysis for a lot of people. And there just isn't the population out there, and that's been available for research until us having the genomic data and that kind of thing, and that's just so critical. But there's new stuff coming out every day.
Definitely. Well, thank you for that. So we're down about 3 more minutes, so I'm trying to get one more question in, and looks like this one's a really great one for Josh. Do researchers have access to our genes and are able to see our EHR or electronic health records, and could possibly contact people with research opportunities?
Yeah. So researchers, when they go through that approval process, which involves their institution having an agreement with them, us as well, and then they're approved and they do the training, then they're able to enter an environment where they get access to your de-identified, so it doesn't have any of your personally identifiable information on it, electronic health records, survey data, and genomic information. And then they're able to do those analyses within our platform. They're not able to take that data out on a row level kind of individual patient basis and do those analyses. Now, we are able to do studies that involve some kind of recontact. We haven't really done much of that yet. We've just started it. So Nutrition for Precision Health, which has a Chicago site, is one of the first ones that's done that, where we've actually, people are being asked if they want to share information about their diet and get randomized to one of 3 diets and learn more about how diet affects health. But we'll have more of these coming. We actually have a number of other partnerships that are starting in this process with other parts of the NIH that will maybe over time, maybe you will actually, some of you will be contacting things. And, I'll say I've been able to see there's way too many questions coming in that I've been able to keep up with. But I've seen a theme of certain people saying, gosh, I'd like to volunteer for a heart study, or I'd like to volunteer for a kidney study or something like that. And so that's good feedback for me, as well as we think about this program, because we might think about ways in the future we actually have ways for you all to see what other studies might be available for you, and may go to develop more of that as a platform. So in the future, it's always great hearing your feedback on those kinds of things.
Great. Thank you for that. And so we're right at time. So I'm going to thank once again Doctors Josh Denny and Kareem Watson for this section of the panel. We still have more to come, folks, so hang on. But for right now, I'm going to throw it back over to my colleague Angelica to give us more information and to wrap us up. Thank you.
Awesome. Thank you, Deidre. So as we come to a close to the next session, we cannot have a participant convening without highlighting participants who have lent their voice, perspectives, experiences, and time to create a better and valuable experience for all participants. And so I just wanted to let you know that there are a few things that participants across the country have been doing for the program. So did you know that you could be a part of different boards and task forces for the program? And the program has many different boards, like we're talking about access to participants and policies and ethics and different things like that, and how to return EHR data back to participants. You also can participate in things like ancillary studies, where you can wear personal health devices and track meals and measure daily eating habits. We also have participants who have spoken at different events. As you can see today, we have both Aaliyah Graham and Adriana Mares facilitating and being participants in this event. You also can partake in different media features. You can chair our participant ambassador cohort group, and you can also help the program create companion materials for dissemination to all of our participants. And since 2018, we have been doing that. We have been meaningfully integrating participants into the program. And so right now we currently have about 42 participants who represent all participants in the program, and they are using their voice to share their experiences, do co-design and co-creation with us to make this program better for all participants. And so if you're interested in something like that, or you're interested in learning more about what those representatives do for the program, feel free to let us know by emailing all of us engagement@nih.gov, and one of my colleagues can put that in the chat. But before we close, I did mention that I was going to briefly mention the poll results. So I just wanted to mention that a lot of you strongly agreed that today helped you to better understand more about the purpose of the All of Us research program. And a lot of you really said that the program openly shares information in straightforward and plain language. So we're glad that you're able to understand all of the information that we're sharing with you. And then we have a lot of you that said that we consistently deliver on our promises and meet expectations, and we'll continue to try to meet expectations for all of our participants. So again, if you have any questions, continue to put that in the chat. I do want to let you know that we are not leaving immediately. We do have time, and we want to stick around and be able to talk to you all and answer any questions that you all may have. And so our leadership is going to stick around. So again, I just want to say thank you, thank you, thank you to all of our participant partners, to all of our researcher and community partners, and our leadership who have participated today. But most importantly, I want to thank you all of the participants who joined us today from the Chicagoland area. We could not have done this without you. I'm hoping that we met your expectations today, whether we did or whether we didn't. I'm hoping that we did. We ask that you take our closing survey today. And so as you can see on the screen, you could use the QR code. We ask that you take that and let us know how you felt about today's event. Again, it was a pleasure having you, and we're sticking around. So if you have the time, if your schedule permits, a few of our program leadership will stay on and some of our presenters to answer any questions that you may have. Thank you.
Thank you, Angelica, and thank you to everyone who's participated thus far. So we're gonna thank you for completing that closing survey. If you know how to scan the QR code, simply take your phone and put it up there with the camera, and that allows you to complete that closing survey. Or you can also go on if you don't want to use it on your phone, you can go to type in that https://allofus.org/Chicago to complete that. Sorry, that was confusing.
Hi, Dr. Watson. So I have a question that we got a lot of questions about security and participant data. So one question I'm going to ask you to answer as we kind of like close out is, how secure is the personal data? How is personal information kept separate from the web available data for researchers? And this person mentioned this is one of the major reasons why people might be hesitant to join the program.
Yeah, thank you.
Okay.
No, please go ahead, Josh. I didn't see you join. Please, great.
Yeah, I'd be happy to address that. I come from a computer science background as well. You know, keeping your data safe is job one. You know, if we don't do that, you know, we won't maintain your trust. And I have all, you know, my data in there too. I'll just, you know, point that out. What we try to do in this process is we really want to be clear with what happens there. And there's some videos online that maybe could be put in some of the questions too, that you can read more about it online if you want to. But essentially, the data that comes in to the participant platforms and the data that goes to researchers, there are a significant number of firewalls between them, and such that the researcher data, you know, does have all that information personally identified, removed from it. And then people have to come into our system to use the data there. And then, you know, we really want to test and make sure our systems are safe. So we do a lot of security testing. We have what are called penetration tests, where we have, you know, people, good guys, basically, you know, come in and try to break into the system and try to find holes that we haven't thought about. We have lots of monitoring of the system to make sure your data are protected in addition. And then, you know, we promise to be transparent that you know, we, if anything does happen with that, we'll let you know. But we're always monitoring, protecting the data with what we're doing, and try to keep, you know, the ways we can get in contact with you and know who you are separate from things like, you know, all your genetic results, to keep that safe.
And Josh, Dr. I did want to add, you know, I too was one of those participants who I don't have a computer science background, even as a scientist. And so I remember one of the last thing I donated was my EHR, my electronic health record, because I had to get a better understanding of who would have access to that. And then, because, you know, I worked at the place at the time where I enrolled, and I was like, oh, I don't want the study coordinator to be able to see my electronic health record data. And it was really clearly explained to me that that's not how it works, that data is de-identified, exactly what you just explained, and that study coordinator at that site, the person who helped me enroll, would not have access to my data, would not have access to the information. But by the time researchers saw that, it was exactly what you said. Numbers were, any information that identified me as me really was removed. And that made me feel safe enough to finally donate my electronic health record information.
Thank you both. I am going to turn it over to a participant who has their hand raised. And I'm going to ask them to unmute, and we'll give it a shot and see if they can ask their question live.
Great questions. You know, I will share, I have an SLC 01B1 spelling change as well. So simvastatin or Zocor especially would also be not recommended for me. You know, those side effects are common with statins. We do know of some of those genetic changes that, you know, do cause, especially some of the more severe side effects. And sometimes people still get, even despite those, at this point, we don't know enough to prevent or predict all the causes of muscle aches with statins. But we do know if you have that spelling change, you're at a much greater risk of having that kind of severe muscle toxicity. You know, I'll tell you, just making it personal, I also have another variant that would affect, if I have a heart attack, what the main blood thinner I would need would be. And so, you know, these can have real impacts like that. I don't know of a study on, you mentioned some of those drugs taken to prevent or reverse osteoporosis. like alendronate, and there's another series, there's a bunch of series of medications in that class called bisphosphonates. Those drugs right now, I'm not aware of a story with genetic predictors. I could be wrong, but I'll tell you that it's actually an example why we need studies like ours, because I actually tried to do a study with some of the more severe outcomes of that about a decade or so ago, and we looked at a large biobank that was available at the time, and we just couldn't find enough people with those severe outcomes. You can get bone breakdown in your jaw and other places, for instance, and it's incredibly rare. I don't want anyone to get the wrong idea about the protection these drugs offer to prevent bone fragility, but it's you need huge populations to figure out why those rare incidents happen when these drugs don't work and cause bad side effects. So thanks for sharing those two stories. It's an example why we need these resources to keep moving things forward. One other set of questions I saw, and I just want to emphasize, a couple of people have asked about moving from one location to the other. And I just want to emphasize, we're a national program, and if you enrolled in Chicago and you now live in Boston or Des Moines, we are still there for you, and we represent the entire country here, and we have partners across the whole country in different places. So rest assured, even if you move to a different place, we are here to support you, and the same phone call and email support lines will work for you as well.
Josh, another question.
Hannah, before we go, just to add to that, they can email help@joinallofus.org if they have questions about that. But we also would encourage those participants to log in, and even if they have issues with their login, because once you log in, you can go to your contact info and you can update your contact information, which would be really great, because that makes sure that we know exactly where you are.
Thanks, Kareem and Josh. Along those lines, we received lots of questions about getting DNA results. Participants are still waiting, and I'm wondering if you could speak to the timeline and what folks can expect if they are, patiently waiting for their results, and who they can reach out to if they have questions specific to their account.
Sure, thanks, Hannah. As I said, we've made a lot of progress in closing some of those gaps. It was one of my big goals for this year. And actually, Kareem, probably should have let you talk about this, because you own that goal of closing that gap. We got to the point where we got about 85% of that or so of that population, but there's still a number of people out there that want those results. And the program as big as ours, that means thousands of people, tens of thousands of people that want results. In fact, I guess there's about 80,000 I know of that are different parts of the pipeline that we haven't been able to close the gap on yet. And so what will happen, one is I encourage you, if you want results and you haven't seen them, just first you might go into the website to make sure that that there's not something there. And maybe you had said it, you wanted it in time, and there may be something there. If not, what will happen is as we're making some changes to our participant platform, the website that you log into over the next couple of months, that we won't be starting to generate new results. Now we're still generating a lot of results from people that are in the process. And then we'll reopen that once the new site opens, and we'll be able to actually close that gap much faster with a test that will be offered in early 2025. And that will help catch up the folks that are not going to get done before then. So we're looking forward to closing that gap. But I would encourage you to log in, check your profile, as Kareem said. If you're waiting on results, just make sure there's not something sitting there that might have some results there for you. And if not, then it might be later that you're able to get that results.
And related to genetic information, someone mentioned that they're nervous about future insurance issues, and they want to feel confident in receiving this information. Can you speak a little bit about that and privacy around the DNA results?
Yeah, so the data results are just for you. It's up to you if you want to share that with your provider, for instance, that kind of thing. One thing that there is a law that was passed called the Genetic Information Non-Discrimination Act, or GINA. That law says that you can't use genetic information for things like whether you can get health insurance. It does not mean, though, that it does not protect you against life insurance. So life insurance and disability insurance are things that can use genetic information in there. And so how you want to handle that, and there's education, by the way, as before you get this result that in the website that reminds you of this fact. But some people may want to get life insurance beforehand if they want to do that. Not all companies are looking at this, certainly, but it is unfortunately one of those things in this country that is still allowed, that they can use that kind of information.
Thanks, Josh. And then again, kind of along those lines, is there specific information provided in the results that can or will determine chronic health conditions that are hereditary from parents to their children?
The results tell you information that is relevant to your health. And if you get the genetic health results for risks of hereditary cancers or heart diseases, these are things that, of course, there's something we can do if we find out that information. About 3% of people will have a positive finding in one of those genes. Those are conditions you can pass on to your kids potentially. Most of those things don't have an impact at young life, but we have already seen conditions in which families, individuals that are part of the program have found out of a result. They told their doctor, if you find one of those results, we have a genetic counselor to talk with you as well, of course. And they would return that information to you and talk to you about it. But one of the things they would talk about is talking to a provider, telling your doctor. And then we've had examples where people came in and found something, they told their doctor, and then they tested their family members. And their family members found out, some of which had the condition, some didn't, and could do something about it. So for the most part, at this point, a doctor would help guide you through that discussion about whether or not it's relevant to children.
Thank you both. So we are going to just answer one more question, and this one is about future projects. What are some future projects we can look forward to seeing from All of Us or NIH that is under the umbrella of precision health or other specific chronic diseases, and how can we get more involved?
Oh, it's great. I always hear people want to get more involved. We are, I think as we move on to this, I'm really excited about moving on to the new platform. It won't be as good day one, just bear with us on day one, but it will get better over time, and we'll be able to do more with you to give you more of those opportunities to enroll in other kinds of studies. One of the things that I've enjoyed is we have this thing called Exploring the Mind in the program, which helps give you quantitative assessments of things like how you think and how much a risk taker you might be with, can you pick out facial emotions, and is something a picture, is it a city or a mountain? They're kind of brain games, so to speak. But we're going to be expanding that to other areas too, to give us ways maybe to understand other areas of mental health and cognition, and to help us define maybe risk factors and how treatments work, to maybe even protect against dementia, things like that. I think we'll see a lot of other opportunities to work with other researchers over time. One of the things that I'll share, one other kind of study that scientists are thinking about now. We know only about what 1/3 of the genes we have do. So there's a whole bunch of genes out there that we don't understand very well. And we have an opportunity to help figure those out. In some cases, we might be talking to participants to think about what some of that looks like. as we figure that out. And so, and some of these things might lead to new treatments for heart disease or kidney disease or diabetes. In fact, we've already seen some conditions like that. The most powerful, the newest cholesterol medicine out there came from studying people's genome and figuring out what a gene called PCSK9 does. And people that had rare variants in that never had heart disease. And so that's become a drug, and it's very effective at lowering cholesterol and preventing heart disease. So maybe there's going to be other answers like that in our genomes that we've shared in our electronic health records.
Thank you, Josh. And so with that question, we are closing down the Q&A portion of tonight. And I just want to share a final thank you to all of our presenters, Josh and Kareem and everyone for staying on this evening, as well as our participants. All of you who have stayed on till this point in the presentation, I do want to remind you that if you did not get your question answered, please email our engagement email, which was on our slides previously, and you can call our support center as well. Thank you, everyone, and have a great night.
Thank you all so much for being with us on this journey.
Thank you.
Thank you. And thank you to the host and everyone for helping us pull this off this evening. Thank you again.